the top of webinar, a tricky liquid, challenges and opportunities in reducing harmful use of alcohol at national level. My name is Maria Renström, and I'm a technical officer at the Management of Substance Abuse team here in WHO headquarters, Geneva. The event today will be presented by Mr. Dag Rekve. He's a technical officer from the Department of Mental Health and Substance Abuse here at WHO, and he will be hosting a live question and answer session to discuss how to effectively tackle the harmful effects of alcohol use at national levels. Dag Rekve holds a master's degree in business and economics and has additional studies in psychology and addiction behavior. He has over 20 years of experience in prevention and treatment of substance use problems at local, national, and international levels. He has worked in a treatment institution for young drug addicts, as a municipal drug advisor, as director of NGO, and as a senior advisor on substance use problems in the Ministry of Health and Social Affairs in Norway. Rekve has also worked as a media consultant and a program manager for alcohol and drugs in the WHO Regional Office for Europe in Copenhagen. So that was a long introduction, and I also know Dag Rekve since far back. So I just want to say some minor practical issues. During the presentation, your micros will be put on mute because we experienced last time that we actually could hear some interesting conversations. If you have any more questions, you can send them to me, Maria Renström, as you can see on the screen, privately via the chat function. A recording of this webinar will be available on the Mental Health Innovation Network. By saying this, I would like to hand over the word to Dag Rekve.
Maria, and welcome to this webinar on which we have called the Tricky Liquid Challenges and Opportunities in Reducing Harmful Use of Alcohol at National Levels. The reason why we decided that Tricky Liquid, that was a framing coined by chairman of the WHO's executive board in 2005, when WHO tried to negotiate the first resolution on alcohol since 1985. And it was in one of the hardest phases of that negotiations that the chairman said that this is really a tricky liquid. And I think that is something which we always have to keep in mind when we are discussing and trying to prevent or reduce alcohol-related harm. That it talks to us at many different levels, and I will try to explore some of these levels here through the presentations that we have. And then we have received a couple of questions before, and we will select a few of them. Finally, by the end of the session, if there are some additional questions or queries, we will try to also find time for them. But first of all, this will be a presentation about the current view from WHO and challenges that one face in the future and here today, and especially then how this can apply to the national level. And the frame for this will be the recent global strategy to reduce the harmful use of alcohol, which was endorsed by all member states of WHO in 2010. Many of the data that will be presented here today are taken from the Global Status Report on Alcohol and Health, which was released here in May this year. If it was not taken from the status report, there will be specific references to the sources. The status report is also available on WHO's webpage for you to download. Alcohol and public health, alcohol consumption, health consequences, and alcohol policies and interventions at the national level. In addition, with appendices with country profiles for all the 194 member states of WHO. Harmful use of alcohol, what is it? Those of you who come from the clinical world are probably used to harmful use of alcohol as a criteria in ICD-10. When we talk about harmful use of alcohol at the political level, it's more a political construct which was agreed language in the governing body discussions here. And what we think about when we talk about harmful use of alcohol is that it is broad and encompasses the drinking that causes detrimental health and social consequences for not only the drinker, but also the people around the drinker and for the society at large, as well as patterns of drinking that are associated with increased risk of adverse health outcomes. So it's a very broad definition. And it's not only about those with alcohol use disorder. So that is important to keep it in mind in the discussions. And use of alcohol can have impact on the drinker, which is very well known to most of us here. I think that it can harm the drinker by its toxic effects on organs and tissues. It can have an intoxication, which leads to impairment of physical coordination, consciousness, cognition, perception, affect, or behavior. And it also has dependence-producing propensities, whereby the drinker's self-control over his or her drinking behavior is impaired. The impact on the drinker, it's also have clear impact on people other than the drinker. And we do not have that much data. We are accumulating data, and WHO is in itself doing a huge multi-site study now together with Thai Health, look into the impact on people other than the drinker in low and middle income countries. But from the studies already collected, we know that alcohol can harm other people than the drinker by its intentional or unintentional injury, neglect or abuse, by default on social role, family member, as a friend, or as a co-worker. We know about property damages, toxic effects on other individuals, and loss of amenity or peace of mind are some of the factors, outcomes of impact to other people that drink here. There is developed a conceptual model for the alcohol consumption and health outcomes. You know from this course that this is very much a contented area with many different views and many different almost ideological differences. When we work out from a public health perspective, we try to find the pathway for how alcohol consumption contributes to health outcomes. And basically, the alcohol consumption is the start. If alcohol consumption is not there, there's no alcohol-related harm. There can be other types of harms instead, but we will not go into that discussion. That's more of a philosophical discussion, I think. When it comes to alcohol consumption, we have identified two main components. That is the volume, that is how much you drink, and it's the pattern, and that is how you drink the volume that you're drinking. In addition, we can say that there are two other components which for some people is very important, others not so, and we have not included them here directly because we still are uncertain about their magnitude. And the one is the quality of control of alcohol, and the second is then the type of alcoholic beverage. We're here talking about ethanol and then the pattern of how you get ethanol into your body. It's the two main drivers in this conceptual pathway. And that leads to certain, or can lead to, have a risk of leading to certain health outcomes. And then be either chronic or acute. And finally, it affects itself then by mortality, by cause, by socioeconomic consequences, and then by harm to others. This is the pathway from alcohol consumption to the health outcomes. And then is the question, what are the drivers behind this pathway from consumption to harm? And the drivers are either at the individual vulnerability factors, we know age, the gender is a factor, family factors contributes, makes you either vulnerable, but also these are protective factors, can be. We know that your socioeconomic status is important in the pathways. On the other side, we have societal vulnerable factors, and that is the level of development, the culture, and drinking context, and the alcohol production, distribution, and regulation. These vulnerability factors intervene in the pathway at different levels, either up at alcohol consumption or down at mortality or socioeconomic consequences. And when we talk about alcohol policy, and this is often something which are kind of frustrating for many of us when we discuss alcohol policy and alcohol control measures. When we talk about policy measures, we are basically only dealing directly with these two factors. Keep in mind that all these other factors which cannot influence directly with alcohol measures, some of them you can influence by other measures at the societal level or individual levels. Others are given. But then today, when we talk about policy measures and alcohol policy, we're only talking of those that influence direct here. And keeping in mind that many other factors contribute in this pathway. When total recorded and consumption, which is combined both of unrecorded and recorded alcohol consumption, we see that globally, at least 6.2 liters of pure alcohol per capita were drunk in 2012. And there are huge regional differences, with Europe clearly the highest region with the consumption. At the same time, you see considerable unrecorded alcohol consumption. And unrecorded alcohol consumption is both everything that is not registered. And it can be illicitly produced alcohol, but it can also be completely legally, informally produced alcohol, or it can be legal cross-border alcohol, etc., etc. And so it's always two components of total alcohol consumption, and that is unrecorded and recorded consumption. And we try to look at the total consumption by estimating both unrecorded and estimating recorded consumption. When we see a bigger spread of the countries and how it is with the total per capita consumption, we see, of course, that it's over total 12 liters in the eastern parts of Europe, especially. Important to notice, but I also would ask you to look at those who are below 2.5 and the belt here in northern Africa and eastern Mediterranean. That is very low consumption. But there is still a big variety in all over the world when it comes to per capita alcohol consumption. Another factor is the prevalence of the pattern of drinking, and we measure the pattern of drinking in heavy episodic drinking, which is defined as far more drinks in one setting in the last 30 days. And again, here you see a slightly different picture, but still you see a big variation in the world. You see that the binge drinking or heavy pattern drinking, it's spread around. It's difficult, but it's really a clustering geographically. Again, looking at Africa and Eastern Mediterranean, you'll see low pattern value, some exception. I think what we often forget is that when we look at total per capita consumption, that is estimated in a year based on the population. And it doesn't account for how much alcohol is in the fact drunk in the world. And how many people are living in the world. And when we now are projecting the future problems of alcohol consumption and harmful use of alcohol in the world, I think we need also to keep an eye on population growth. And you see the world continue to grow. This is the median estimates from the United Nations probabilistic population projections. And I think what is important here is that the world population is growing, but I think what is really important to notice is Africa and how consumption is the population is growing rapidly in Africa, with child mortality rates going rapidly down. And at the same time in Asia it's flattening out. In Europe there's not much movement than in the other regions. And another interesting point is here is the same shown. In fact, that is only till 2015. And this is the core drinking population. So here I removed those are under 15 and those that are over 65, just to look at the drinking population in the world. And you see a dramatic increase in Africa and in Asia. And it means that independent of if everything ceteris paribus, the total alcohol consumption in the world will increase dramatically the next 30 years. And if everything is equal, that means also the level of alcohol use disorders, the level of harmful use, the levels of injuries, the violence, the pressure on the health system will increase at the same time, even though per capita consumption is at the same level or is reduced. Of course, there are many variables here, but I think it's important to keep this in mind when we think about alcohol policy developments, especially in low and middle income countries. Especially if you also combine it with prevalence of past 12 months abstentions. Because remember I said that in Africa and Asia had the highest population growth the next 30 years. And look at the level of abstention here. These are 60 to 100% abstention rates. And exactly in the regions with the highest population growth, in the regions with the highest abstention rates, which means that there are two variables here which can be detrimental for the future development of alcohol-related harm in the world. And that is, if any movement happens in the abstention rates, especially in these high growth populations, we can have a dramatic increase in the alcohol-related harms in the world. And more importantly, population growth will continue for 30 years or more. Most people in the world do not drink alcohol, and especially so in areas with high population growth. The future looks very bright for the global beverage alcohol industry. The problem is that potential growth is most likely already reflected in their market values. And this implies that the total burden from harmful use of alcohol, in fact, has to go up to serve the wealth of the alcohol industry's shareholders. Because this is one of the real dilemmas, and the reason why I'm mentioning this is that this is really one of the dilemmas that we have when we talk about reducing harmful use of alcohol at the national level. That is that we hurt the alcohol industry, and I will come back to that a little bit more. And what I've been trying to show here that, we've hurt the industry, even if you try to keep the per capita consumption at the current level and reduce the harms from it. So there are a lot of issues here, and this could be a kind of food of thought to bring with us in the rest of the presentation. And when it comes to health outcomes, we measure it in the global burden of disease, and that is the concept we use is disability-adjusted life years lost. And that is years of life lost due to premature mortality in the population. And it's also years lost due to disabilities for people living in the health condition or its consequences, often by a weighing of the disease. And I'll go into details. There's a lot of information on the web out on this, but basically, this is the formula. This is the crude formula for trying to measure the global burden of disease in the world. It can either be measured by the cause of disease or injury, or it can be measured by the risk factors. And this is often confusing for people, even myself sometimes, to keep the tongue right in the mouth there. Because of alcohol use disorders is a cause of disease and injury, but alcohol use is a risk factor. So that is, when we talk about the global burden of this, is always important to keep in mind if we are talking about the risk factors, or we are, of course, talking about the causes. We'll mainly talk about alcohol use as a risk factor in the presentation. And when we look at the global burden of disease, the last institution that measured it was in 2010. There are different measures out there, so we need to be aware of that. This is the last comparative risk assessment, and that is from the Health Matrix Network in Washington. And there we see that tobacco was measured. The second, drug use is down. Tobacco is here. Drug use is here. And use, fifth leading factor is here. And here you have all the conditions or the diseases. Sorry, my drawing skills here, but anyhow. And what I think you should key on is when you see the colors. When you see colors in the, I just need to mute the person with the background sound. They're able to mute the person. Sorry about that. If you look at the color range when it comes to alcohol use, I think it's important to keep in mind that alcohol use is involved in so many conditions and injuries, which really, compared to others, stands out there. Another thing that stands out, and now I partly destroyed it, is of course that we have included beneficial effects of alcohol consumption on diabetes and also on the cardiovascular diseases. And that also makes alcohol stand out from the other risk factors, that in fact the beneficial effects are, for reasons, included for alcohol, but not for many of the other risk factors where beneficial effects could have been included. So what we are talking about here for alcohol use is the net effect, in the beneficial effect subtracted. So also keep that in mind. Another way to look at it is then how is the alcohol attributable burden of disease when it comes to all the alcohol dailies. And here you see again the rainbow of and how it is part of neuropsychiatric disorders, cardiovascular diseases, cancer, neonatal conditions, mainly FAS, intentional injuries, unintentional injuries, infectious diseases. This in fact is new. First time now that a causal link between alcohol and infectious diseases is accepted in the global burden of disease, and then gastrointestinal diseases. That means that if you only look at alcohol use disorders, we are getting part of the picture, and we need to look at a much broader panorama when it comes to alcohol, harmful use of alcohol. Another important factor with alcohol is when you look at the different, for example, we look at the difference between smoking, drug use, and alcohol use. When you look at which ages, these are the deaths, and it's global. You look at, of course, secondhand smoking, very early life, but then alcohol, very early in life, is an important factor for global deaths. Tobacco, of course, comes much later in life. And here also many of the secondary effects of alcohol is not included in these estimates. And especially this development in other psychoactive substances. I sometimes call alcohol no ordinary psychoactive substance in a way to point that, in fact, alcohol is a psychoactive substance, and we want to look at it from a psychoactive substance point of view, or do we want to look at it from a commodity point of view and normal goods in society? And we have many challenges now in the other psychoactive substances, and I don't have time to go into detail about them, but you can see them here, and everything is now coming together in the United Nations General Assembly session in 2016 about the world drug problem. But wanted to highlight this because especially when we see in the cannabis discourse how often one refer to alcohol being more harmful than cannabis, and then logically from that cannabis should be less regulated than alcohol. And I think here are some missing links in the discussions, and we hope here in WHO also to point much more into the public health effects of all types of psychoactive substances, and that should be the starting point for our discussions. In addition, we see now that NCDs is becoming a major focus in the world, and we have had several, and we see that harmful use of alcohol is part of the NCD problems and recruitment as a risk factor for the NCDs. And we had a political track also with, we have a political declaration in the UN on NCDs, and we have a global action plan for prevention of NCDs here in WHO, where harmful use of alcohol is one of the 4 main risk factors. But again, keeping in mind that alcohol-related harm is much more than NCDs. We're talking about neuropsychiatric problems, injuries, and violence, which are, of course, the broader NCDs, and communicable diseases, in addition to the harm to others perspective. And what can we do about it? To work on the levels of alcohol consumption. We have to work on the patterns of alcohol consumption, the context of alcohol consumption, and the wider social determinants of health. In addition, special attention needs to be given to reducing harm to people other than the drinker and to populations that are a particular risk from harmful use of alcohol. In fact, the world were able to agree on a global strategy to reduce the harmful use of alcohol in 2010, in spite of alcohol being a tricky liquid. And I think that is important from the national point of view that in fact all 194 member states of WHO have signed up to, have endorsed this global strategy, and everything that is in the global strategy has relevance for the national level. But of course, it has to be tailored to the specific situation in the global strategy is a non-binding instrument. And in fact, for the other psychoactive substances, we have legally binding instruments like the Tobacco Framework Convention and like the three international drug conventions. The alcohol strategy is then a non-binding instrument, but at the same time, in fact, all member states have set up to it and morally binding to its implementation. Strategy, there are 10 recommended areas. From time now that I probably have to skip going in detail through these different areas, but you can read a lot about in downloading the global strategy, and I think there are a lot of dilemmas and guidance in the strategy about all these 10 areas, which I really encourage you to read. We can just go through the leadership and awareness, for as an example. And the strategy says that sustainable action requires strong leadership and a solid base of awareness and a political will and commitment. And I think that is a big problem in many countries, that it's very difficult because alcohol is such a tricky liquid and because there are so many other urging problems and there are really not anyone really advocating strongly for a public health approach on alcohol. It's very easy to neglect alcohol. It's very easy to push it under the carpet. It's very easy to try to focus only on the heavy consumers or the addicted persons, and trying to say and blame them and say this is not really a problem and we shouldn't harm normal consumers. And then that is really a pathway to problems, especially in some of the developing countries that I referred to in the population growth perspectives. And it should ideally be a national intersectoral policies and plans. Policies must be based on evidence, but at the same time tailored to local circumstances with clear objective strategies and targets. And the policies should be accompanied by specific action plan. Engagement of civil society and economic operators is essential, and I will come back to that a little bit later because this is one of the questions we got. And the strategy mentions a lot of different areas, and I will skip them, and I will now go to a slide. Let me see if I can find the right slide. Now we are in the implementation phase of the strategy, and we are developing technical tools to help the countries and supporting the countries in defining their own national policies. We are creating in-depth research material for especially challenging areas like pricing policies, like availability and marketing, but also other areas. We have regional capacity building workshops. We have direct technical support to selected countries. And we have continued the implementation of WHO audit and assist packages, which are more linked to harmful use of alcohol and dependence problems. And developed a generic portal now on alcohol health in 4 countries with a drinkless package and self-help tool. And again, I will come a little bit later to that. The key message in my presentation has been that alcohol is a toxic and psychoactive substance with dependence-producing propensities. Yes, it's also very much ingrained into the culture. It's normalized in many cultures, but it's also not normalized in many cultures, and we have to keep that perspective. It has a function, it has a social function for people, both at the individual level and at the social level. Having alcohol, not alcohol is often called, in my country, if alcohol is not present in a party, you redefine the party as a meeting and not as a party. And in fact, we have a lot of cultural, not dependence, I would say, but it is so ingrained in the culture that it's often very difficult because we are triggering a lot of emotions. Alcohol has been successfully linked to freedom, freedom of choice. It's a little bit strange that the dependence-producing product has been linked to freedom of choice, but at the same time, we need to balance all these things. That alcohol can also be drunk at very low risk in settings. and it's culturally ingrained, and it is linked to food. And we have to then balance from a health point of view, how can we reduce the public harm from this product? And we think here that we have to start with the fact, and that is that it is a toxic and psychoactive substance, but also it's clearly distinguished from other psychoactive substances in many different ways, and we have to keep that in mind when we are defining policies. Harm of alcohol is a global health issue, ranking among the top 5 risk factors for the global burden of disease. At the same time, most people in the world do not drink alcohol, and paired with the continued population growth can constitute a considerable challenge for the health system in the future. Not especially the health system, with the growing population. The use of alcohol has considerable detrimental effects on other people than the drinker. We are starting to accumulate more knowledge on that. Finally, the burden from harmful use of alcohol can and should be effectively reduced. So I stop there at this time and are going over to the question session. But perhaps, Maria, you would like to come in now at this level.
Yes, thank you very much, Dan. This was a very comprehensive presentation, and I'm sorry that we can't have much more time because all the other slides would also have been interesting to listen to. I just want to repeat, because there are some newcomers since we started. If you have any new questions that you haven't been able to put forward before, you can do that to me, as you see Maria and me on the screen. But I think that we have so little left, around 10 minutes. And this will be recorded, so you can listen to it once again. So I would like to start with one of the questions that we already received. Are you ready, Dag?
Yep.
I have had a question on, in the UK, there has been much debate about the use of a minimum price on alcohol to reduce excessive drinking. Is there evidence to support this approach? What do you say, Dag?
Maria, and thank you very much for the question, which is a very interesting question, because minimum pricing has become one of the hottest political topics when it comes to alcohol policy formulation, especially in Europe, but also in many other countries. And, in fact, we do not have much evidence as such from minimum pricing. It's been tried in Canada and a couple of other places, and those shows that minimum pricing an effect. And we have a lot of modeling exercises, especially from Sheffield, which clearly indicates that minimum pricing might be a clear addition to taxation as a pricing policy measure. And the reason why I am trying to explain in this graph that you see here. So you look at different beverages here. So here we have 10 different beverages with a different price. Sale price. The producer price is the blue line. And some products are very low priced and can be produced very cheaply. And others have a additional value and can be priced much higher because it's an additional value to the consumer. Some have all higher production costs. For example, traditionally have higher production costs than spirits. As one example. So when we introduce taxes, and here is a very simplified. Those of you who know very much about tax and pricing policies know that this is extremely simplified. But basically, what taxation tries to do, and here it's a uniform tax. This is a value-added tax, ad valorem tax. It tries to just shift the price of the product up. And tax then, if you have an ad valorem tax here, it just shifted. No, sorry, this is a flat tax. And it shifts the price up basically on the product. But the minimum price, and so still, it might be very low priced in the marketplace in spite of taxation. That's the case here. Sorry for the confusion. I want to even perhaps say that no, this is far too low price for alcohol. We don't want to heighten the entry price for alcohol for the consumers. And that might be very difficult only the taxation system. You can manage it with taxation system. But that is very clever, where you have to have very high access on the ethanol content of low-priced products. That can be very tricky. So instead of trying to do this mathematics, you try to say, okay, we put a floor. Below floor, alcohol is not allowed to be sold. How minimum pricing can come in.
Can I add a question to you?
Yes.
Isn't it also the fact that all of these very low-priced alcohol products are quite attractive to young people and people that might drink a little bit too much? Isn't that also the case?
Well, now we're talking about the so-called price elasticity of consumers. And it's a very tricky issue, but we know that, yes, low-priced alcohol is very appealing to those who want to seek most highs for lowest price. That is often dependent people, and it is young people. So, of course, the low-priced alcohol can have a special appeal to young consumers and to people with alcohol use disorders. No doubt about that.
Okay. Can we move to question number 2, or is there something you would like to add?
No, I think it's fine. The point is that it is a complicated issue, but yes, minimum pricing clearly have a place in the pricing policy strategies. The question is how it interferes with informal and illicit alcohol, but that is a bigger and also difficult question. But yes, we think from our point of view that minimum pricing should be part of any pricing policy strategies and at least be discussed, keeping in mind constraints, whatever might be legal constraints in countries or unions. Yeah.
Thank you. I will put forward question number 2. This is a totally different area. Dag, are you aware of any online public health interventions direct to consumers, carbon engagement, assessment, and treatment? And if so, what were the results of this?
Thank you again, Maria, and thank you very much for the question, which is very interesting question. And I think there are many online interventions, many online packages for consumers or people who are seeking help for any problem drinking out there. I don't want to mention any specific now. I will come back to one specific later on. But I think what is important to keep in mind when we talk about these online intervention packages or information packages or self-help packages or portals or whatever, is to keep in mind what are the target group for the information there. There are many target groups, and there are many needs for help. Look at this pyramid about where you have risk drinking in a huge part of the population, and then you move into hazardous drinking without really having manifested itself in any harmful. And then you have harmful drinking, which starts manifesting itself in real problems. And then you have moderately dependent drinking, and then you have dependent drinking, and then you have severely dependent drinking. And we know from the evidence basis that on intervention tools, probably the most effect in this group. And many of the online tools are targeting this group. And we look at the more dependent drinking, it might be that in a stepped care approach that online tools can have an effect, but it's very difficult. And still think that here you need to have face-to-face counseling and treatment services in the health sector.
No, so you can say that, I mean, you need to have different approaches to different target groups also when you talk about this kind of more interventions.
Yeah, clearly. And also, in fact, independent of what you're dependent on, also, we see differences between alcohol, tobacco, and illicit drugs, for example. Just to like here, I think I could mention one portal. I'm not sure if I can get it up here. I had a link to it, but I don't think it comes up. No, we have a portal in 4 different countries, in India, in Brazil, in Mexico, so it's in 4 different languages. We have a drinkless program, we have an intervention package, we have an assessment tool, and we are going to have a huge randomized controlled trial now this year to exactly measure the effect of that intervention, and I think that will be very interesting for us.
Now, Dag,
Yeah.
I need to put forward one more question, I think. So, should we be concerned about the alcohol industry's interference affecting national alcohol management strategies? So what would be your answer to that?
My answer to that, I'm not sure if the person who pointed the question wanted to get me sacked, but because this is extremely contagious question, it's extremely difficult, and it's so politically, but at the same time there are many issues around it, and I'll try to answer that from as objective point of view as possible, and pointing to challenges we have in this part, also real possibilities to have the alcohol industry contributing to reducing harmful use of alcohol. Basically, we have to look at it from a broader perspective and then only management of strategies. Why is the alcohol industry involved socially around alcohol-related issues and society in general? Of course, we have many motives from the alcohol industry. First of all, social corporate responsibility and the triple bottom line now is a big thing. And no company cannot but be having social corporate responsibility policy, and especially when it comes to correcting market failures of their own products. So you can, from that point of view, there is a legitimate place for the alcohol industry and alcohol using alcohol-related harm. So that the involvement can be based on that, in fact, in the consumer world today, in the marketplace, you are rewarded from the consumers if you portray yourself as a socially aware and responsible company. It also can be an internal feel-good tool inside the industry that, yes, we are contributing positively to society. Any company wants to do that. But public health point of view, there are two which are things which you really have to keep an eye on. That is when this social corporate responsibility becomes or are in danger of becoming a kind of generic market of alcohol in society, shaping our perceptions of alcohol, or even brand-specific marketing, which I'm not sure if you see on the picture down here is the latest campaign from Stella Artois and InBev Anheuser-Busch on water supply in the world. With this campaign of Buy a Lady a Drink, which can be very much misinterpreted in a way. But if you buy this glass, you can secure the water supply for this woman for 5 years. And this is, of course, legitimate from one point of view, but at the same time, when we know how much water beer demands in the production, and we know, especially this is a woman from India, and the high abstention rates, some people might be provoked by this. So the fine-tuning, the involvement of the alcohol industry. But I think, first and foremost, what we have to be about in the policy formulation is when the involved from the interference from the alcohol industry becomes a hedging against government regulations. Yeah. And that is often difficult to say when it's not, when it is and when it's not. From WHO point of view, we have a clear standpoint in the global strategy that yes, there is a place for the alcohol industry in reducing harmful use of alcohol, especially in the value chain, but at the same time we need to keep very much eye on potential vested interests and conflict of interest. Yes.
Okay, now the time flies, so to conclude this, they should be responsible in their own businesses, not in public health policy. Okay, I think that we have now passed with 1 minute, so we are quite on time. And I just want to thank you everybody that participated, and that this recording is also available on the webinar on Mental Health Innovation Network page. Thank you, Dag, and thank you everybody that has been listening.